Good evening and welcome to the Tomorrow's Podiatry series, Two Views, where two podiatrists are encouraged to complete some antagonistic cooperation via some friendly debate. Thank you to both our live viewers and our future recorded audience for joining tonight. My name is Nancy Kelleher and I will be your host. Tonight we are joined by team captains Zoe Wilson and Liam McManus alongside their expert speakers. I will pass it over to my team captains to introduce their experts. So first, Zoe, do you want to hit us off with our expert speaker for tonight in your team?
Good evening, everyone. Thank you very much for joining. I am thrilled to present a specialist consultant foot and ankle surgeon based in Surrey and London, Amit Amin. Amit adopts a pragmatic and careful approach to clinical decision making, working closely with a range of professionals, including podiatry. Thanks for joining us.
Thank you so much for joining, Amit. I cannot wait to hear what you have to say on this topic and to hear what you and Zoe have come up with. I'll move it over to Liam now to introduce your expert speaker for tonight.
Thank you very much. And how long have you got for my expert here, Mr. David Gordon? But first of all, I'd like to thank both experts for really giving up their time to discuss minimally invasive hallux valgus surgery versus traditional bunion surgery. It's a pleasure to welcome both Mr. Amit Amin and Mr. David Gordon to this webinar this evening. They have a wealth of experience and are both actively involved in R&D. It's my honour really to welcome my expert, Mr. David Gordon, discussing MIS surgery. David is one of the top London surgeons, certainly within the UK as well, leading the way in minimally invasive hallux valgus surgery. Dr. Gordon is an orthopaedic surgeon specialising in the foot and ankle as well as trauma. Has been practicing since an impressive 1998. He's undertaken fellowships in Sydney, Australia. He's held honorary lecturer at the UCL. Spent 6 years in specialist training at the Royal National Orthopaedic Hospital in Stanmore, and he's also undertaken research developing in amputation prosthesis, being awarded, and I'm told, one of the most prestigious awards in orthopedics, an MD in higher postgraduate medical doctorate. He's published extensive research, international journals, written chapters in books in a lot of the major orthopedic textbooks, and he's presented his research globally. He uses state-of-the-art equipment and techniques, delivering around 400 surgeries per year and sees around 900 new patients annually, practicing within central London and within Hertfordshire. So it's my privilege to welcome both orthopaedic surgeons and, importantly, my expert tonight, Mr. David Gordon.
Thank you so much, Liam, and thank you as well, David, for getting involved. As with Amit, I'm unbiased. I'm very excited to hear your point of view also. But before we do that, let's go through what we're going to discuss tonight. So we'll be discussing the topic bunion surgery, traditional versus minimally invasive surgery. This topic in general is absolutely a subject of interest in current podiatric practice due to our role in managing patients with painful hallux abducto valgus, but also due to the growing population of podiatric surgeons in our large podiatry family in the UK. So we hope tonight's session will appeal to a lot of our viewers. There's so much to cover. We could create a single series on this topic alone, but tonight we'll try and include as much detail on this complex topic as we can to start us off at least. So the outline of tonight will be as follows. We've changed the format slightly, but we will be starting off with our experts giving a brief 10-minute discussion on the subject. We will then give each team 3 minutes to provide their argument for why one of the modalities has greater benefits in clinical practice than the other. Following this, we will then have some time to open the conversation up to the audience, where we will discuss your questions and comments that have been placed in the comments box below. So please get involved and we'll go through all of that towards the end of this. And finally, each team will then be provided some time to summarize their argument, and then we'll come to a close for this evening. Before we let each team go ahead, let's start rolling in some views from our audience. So we have created a poll for the audience, which is now open to complete. So our poll will be best bunion surgery technique, minimally invasive surgery versus traditional. Please, everybody, feel free to submit your vote. You'll have the entirety of the session to submit this, and then the overall finding of our poll will be published at the end of the session, which will technically be our winner for this evening. So no pressure, guys. So if you feel passionate enough, please drop into the comment section and let us know why you've submitted the response that you've submitted. And if you're on the fence and you feel like a question would help you get to the response that you want to go to or your decision, just put that in our comment section as well. And as I said, we'll address that whenever we get to that time. Right, let's get down to the question at hand. I'm going to pass it over to our teams. We'll be starting off with Amit Amin, and he'll be doing his presentation as part of Zoe's team today. Just get your presentation open. First tech glitch of the night. It's a good sign. There we go.
Good. I'm good to go, am I? Yeah.
Good to go.
How do I move my screen forward?
I think you need to go into presentation mode at the bottom right hand of the screen.
Got you. All good now?
Yeah.
Perfect. Well, thank you very much, Tomorrow's Podiatry. Thank you, Nancy. Thank you, Zoe, for the introduction. Thank you, Liam and Michael. My name's Amit Amin. I think Zoe's introduced me. I'm a foot and ankle surgeon. I spent 7 years at St George's as a consultant in the NHS, and I left it's about 7 years ago now. I work purely privately in London, at London Bridge, One Welbeck and Parkside. Obviously, today I'm pitted against my good friend and colleague, David Gordon. And hopefully after me and Zoe are finished today, he's still my friend. So I'm going to talk about open bunion surgery and why I do the surgery through an open approach. And what I'm going to talk about specifically is the open scarf and aching osteotomy. Now you see a picture here of the scarf osteotomy, and those of you who are keen in carpentry will understand the term scarf joints. And you'll see here in terms of how the metatarsal is cut in a Z fashion. And that's described to be a very stable way of putting two pieces of wood together. And it's also a very stable way of cutting a bone. So when we cut the bone in this fashion, we can move it, we can translate it, we can rotate it, and it can remain very stable without any obvious shortening. And clearly we fixed these osteotomies with screws, but inherently this is a very stable way to cut a bone. What I would say about this surgery, and here's an example in the bottom right here of a traditional bunion with a traditional open bunion surgery where the metatarsal has been translated, it's been fixed with screws, and you can see a very nice correction. What I would say about the technique is that it is technically demanding. I'm 12 years into practice, and I would say that I'm only just now coming to the end point of meeting all the various complications that you can encounter with bunion surgery, and the learning curve is extremely steep. So why do I specifically do open bunion surgery? Well, firstly, it's the gold standard treatment for bunion surgery, and that's very clear. Most surgeons in the UK perform this procedure through an open approach. And the most commonly performed procedure itself is the open scarf aching. So much so at the recent British Orthopaedic Foot and Ankle Society meeting in Liverpool, we had the exact same debate, the open versus the MIS. And I won't tell you who won that, but I'll let you make your own decision based on what you hear today. What I would say about open bunion surgery is that it's reliable once you've been through your learning curve. The results are very good, but it does require proper training. And I've highlighted the word training, so I'll come back to this. This is exceptionally pertinent when it comes to minimally invasive surgery. Well, now, if we're doing a procedure which is the gold standard, it's reliable, the results are good, then it begs the question, if it ain't broke. But who wants to stop in the way of progress? Minimally invasive surgery is on the up. It's certainly commonplace in many other specialties, laparoscopic, urological surgery, laparoscopic general surgery. So, minimally invasive surgery is certainly is a way forward. It's a way of progressing medicine. But whenever we bring in any new treatment, we have to compare that treatment to the gold standard. We have to ask the question, is it any better than our traditional gold standard? And therefore, we should then move to the evidence. Now, if we're looking at the evidence, what we're really looking for is level 1 studies, if possible. And that's essentially a randomized controlled trial. Now, we know in orthopedics in particular, it's very difficult to put together high quality randomized controlled trials for various reasons, logistical, ethical. But if we look at the literature and we look at the 2 randomized controlled trials that I was able to find, 2019, we see the conclusion of this fairly small study was that the results of minimally invasive chevron versus open surgery were comparable to the open technique, so only as good. And if we look at the second, more recent randomized controlled trial, slightly larger study, and this study again confirmed the conclusion was that the clinical and radiological outcomes were equivalent to the open approach. So at the moment, the randomized controlled trials are suggesting that the minimally invasive approach is about as good as the open approach, which in some eyes, some people would say, well, that's enough. Let's move on to training and the learning curve. Now, this is, in my view, probably one of the most important considerations when it comes to perhaps choosing your minimally invasive surgeon. Like most minimally invasive surgeons out there are in their early learning curve. Very few are like my colleague David Gordon today I'm pitted against, who of course is an expert in the procedure itself, who's done many, many cases. But if the learning curve with open surgery is steep, the learning curve with minimally invasive surgery is probably even steeper. And how many trainees do you think are exposed to minimally invasive surgery in training? And I would say, given the fact that most of us up and down the country do this through an open approach, that very few trainees actually come across this. And therefore, their learning curve will start as a consultant. And if you're a patient with a bunion, I think you need to ask yourself the question, would you want to be a patient of a surgeon in their early learning curve? I certainly wouldn't. This is a patient who was in the early learning curve of a minimally invasive surgeon on the left, had their surgery and the bunion was still there. And you'll see this slight generalized swelling around the toe as well. And this patient had not only a undercorrection, they had a very rare complication of avascular necrosis, which led on to arthritis. And essentially I had to perform a salvage operation. This was a open bunion correction with cheilectomy. And you see the picture on the right, things seem to have settled down. Patient was certainly happier, in fact, painted her nails when she came back to see me at 6 weeks. Let's start busting some myths, I think, about minimally invasive surgery. Now, I'm sure you're going to hear David say and talk to us later about a number of these factors. So let me address them before he says them. Firstly, the scars. Now, scars in minimally invasive surgery are small. There's no doubt about that. But I'll show you some examples of scars with open surgery in a second. The recovery is quicker with less stiffness. I'll come to that point as well. Bigger deformities are corrected by minimally invasive surgery. I'm sure you'll hear David talk about this as well. There are a couple of myths that I'll just bust right off the bat. Firstly, surgical time is quicker with MIS. Well, open bunion surgery takes 30 to 45 minutes. I put it to you that a patient that comes to you with a bunion, what they want is an operation that's technically executed very well. They want to have a perfect bunion correction that lasts them their lifetime. And I think 30 to 45 minutes is good going. Secondly, the recurrence rates are less as the first TMT joint is locked with MIS more effectively. Now, this is what David, I'm sure, is going to talk about. And what I'm addressing here is if one looks at the first TMT joints, I'm not sure if you can see my cursor, but if you can see the first TMT joint here. Now, this is where a bunion originates from. Now, when we do a open scarf osteotomy or any osteotomy to correct a bunion, what we want to do ideally is pull the proximal fragment inwards as much as possible. If we do that, then we're calling that locking the first TMT joint. Now, if we're able to do that, then, and we push the metatarsal head in enough, so it's covering the sesamoids, which is a principle of bunion surgery, then technically, having pulled this inwards as far as it wants to go, this bunion should never come back because we've tightened this joint significantly. And you can see this is an example of the first TMT joint being pulled in and locked in. Now, I would say that I'd probably give this one to David, that you can probably tighten the first TMT joint more effectively with MIS surgery. But what I would say is that in mild deformities, I don't believe it's a factor, but in more severe deformities, I often tell these patients, look, we're going to make your bunion much, much, much better. It may not be 100% perfect, but I'm very confident that you'll have a good outcome still. And a lot of these patients will have a mild early recurrence or a mild late recurrence. Very rarely does this need further surgery. And I would say that outcomes are still typically very good. So we're not looking for the perfect X-ray, we're looking for the perfect outcome. So let me just run through these myth-busting comments above one by one. So this is a scar. Now this is actually not even my best scar to show you. This is probably in the middle. And this is a patient who had a bunion operation. They were 3 months out. You can see, firstly, the range of motion is pretty reasonable. You can see a slightly stretched scar proximally, a scar distally that's fading away. Now, if you fast forward to 1 year post-surgery, the scar has essentially faded away into nothing. So in my view,
we seem to be having a slight technical difficulty with yourself there, Amit, for just one moment. So I'm going to get you to pause and we'll come back. Unfortunately, as sometimes happens in all of these situations, technical difficulties come through. But so far, seeing ponytails coming through. Amit, I'm going to just take you to pause for just 1 second, if that's okay. We're going to try and get back, much like on Today's Show, when we get to that stage where we lose.
It's really not a factor to consider when you do. Recovery is quicker with MIS. Would certainly beg to differ. Here is we're cutting the bucket. So essentially, we're creating a fracture 6 weeks to heal.
Okay.
If a patient presented to you with a
I'm very sorry because we are having some problems with Amit there. So what we're going to do is we are going to take a wee break there and try and re-establish with Amit. And we are going to bring back on Gordon and Liam. Gordon and Liam, how are you doing there? You all right?
Thank you. Yeah, thank you, Michael. Yeah.
All
good.
We get these technical bits in there. We will try and re-establish. So what we will do is we will take a pause. And Nancy, if that's okay with you, we will taking Gordon's starting point and try and come back to that. Unfortunately, this is one of these things. It's David. I keep saying Dave Gordon. I'm sorry, David. I am so sorry.
Don't worry, Stevenson. It's fine.
Yeah, it's just all right.
No, it's all good. Common mistake. David is my first name. Yeah, no worries.
And it's an absolutely no excuse there, David. I am so sorry. I've done it twice now, and it's there for you. So
that's
okay.
Cool.
So what we're going to do is while we try and
glad Amit has shut up now because I'm chomping at the bit.
I think it's only fair considering at the moment the poll is sitting at 100% traditional over minimally invasive. So David, I shall pass over to you to try and see if you can change that slightly and bring that a little bit more to the other way.
Perfect. Thanks, Michael. Right. So let me just share my presentation. Good. Can you just, am I good to present? You can all see my slides?
Yeah, we can see it.
Perfect. Great. Well, thank you very much to tomorrow's Podiatry Live panel for inviting me. Very excited to be here, particularly to pit myself and minimally invasive surgery for bunions against Mr Amit Amin. So my name's David Gordon. I'm a consultant foot and ankle orthopaedic surgeon. I'm based in London and Hertfordshire. I work at the London Clinic, Spire Harpenden Hospital and Spire Bushy Hospital. Thanks very much, Liam, for the very lengthy introduction. You're making me blush. Right, so if you want to follow me at The Bunion Doctor, I'm on various platforms, Facebook as well, but predominantly LinkedIn and Instagram. So a bit of background about me. I've been performing minimally invasive foot surgery for about 10 years now, just approaching about 1,000 hallux valgus corrections. But I'm a fellowship trained foot and ankle surgeon in the scarf osteotomy. So I grew up in my training performing scarf osteotomy. So I'm in a position to speak of both techniques. I also like to collect data. I've got a large patient outcome database solely dedicated to studying long-term outcomes in minimally invasive foot surgery. And a couple of years ago, I published the biggest series in the world of minimally invasive chevron aching, or MICA, in the JBJS America. If you want to get in touch and you want to have copies of any of my papers, please get in touch. And I do get invited very kindly around the world to lecture on the subject. So my disclosures are that this is a very blurry Mr Amit Amin far left, and this was at the British Orthopaedic Foot and Ankle Society last month at the annual conference in Liverpool. So me and Amit do go back a long way, and it's great to spend time with him. But I will be taking no prisoners this evening. So is this good versus evil? Well, clearly I'm the Luke Skywalker. Mr Amin, the open bunion surgeon, is Darth Vader. So what is minimally invasive surgery for bunions? Well, it's percutaneous surgery, so it's going through the skin, small incisions, 2 to 5 millimeters, and the principles are the preservation of the soft tissues. You can perform bony corrections using specialist instruments called burrs, and then the bone is internally fixed. So what I'd like to do is run a 3.5-minute video of me performing a fairly standard routine minimally invasive bunion correction. So over to you, Michael. And what I'll do, I'm just going to talk through fairly straightforward, moderate bunion here. Prepped and draped, ready to go. Some small incisions. There's the first one for the burr. The second one are for the screws. And I'm going to start off by making a chevron or arrow-shaped cut in the distal metatarsal. I'm placing the burr on bone, checking its position, and then I'm just completing the cut now. And once the cut's complete, I've got a mobile distal metatarsal head, which I can then change and correct the rotation of the deformity, which is really important in bunions. I can translate the metatarsal head laterally to close down the intermetatarsal angle like this. And then I'm going to fire a wire from the base of the metatarsal into the metatarsal head to hold the correction stable. Then I place a second wire because I'm going to place 2 screws in that position. And I swap those wires out. I measure the wires, and then I drill. And then after drilling the hole, it's a cannulated system. So the screw feeds over the wire, and then the wire stays in position while the screw goes over it. And I screw the first screw in, and that's what you can see in the X-ray. And then the second screw, I drill, feed the screw over, and fix the correction with 2 screws. So that's pretty much the operation done, but then there's some sort of fine tuning. There's a spike there on the medial side, which the patient would feel. So I remove that with the burr. And the patients are sedated. There's no general anaesthetic. So that's the spike removed. And then I do a little bit of fine tuning just to take some of the bump off the side of the foot. And the patients had an ankle block. So, and lots of my patients are awake during the surgery. I can talk them through the whole operation. And then sometimes I do the Aiken osteotomy, again, percutaneously, 2 small incisions, again, using the specialist burr. So I cut a wedge out of the proximal phalanx. So there's my wedge, and then I'm going to close down the wedge. And by closing down, I can correct the hallux valgus angle a little bit more if I want. I'm going to fix that osteotomy with a screw. So I plan a wire, which is where my screw is going to go. And then I'm going to drill over that screw and then, sorry, drill over that wire and then place a screw over the wire. And then we're done. So that's the end results. There's a lateral view. And that's, yeah, the incisions are so small, no stitches required, just some stereo strips. That's before and that's after. Bandage on the foot, before X-ray, and after, before photograph, and after. Okay, so I'll carry on with my presentation. Right, so top left, this is what we used to do for ACL reconstruction. A horrible, open, soft tissue disruptive procedure. But guess what? We don't do that anymore, do we? We do it arthroscopically, which is the other picture, through some small incisions around the knee and do an ACL reconstruction. So why should we be doing a bunion correction through an open technique still? Would you rather have incisions like this on the right or like this on the left? There are a whole range of advantages for minimally invasive hallux valgus surgery. And I'm going to go through one by one this list. First of all, you can treat the full range of severities of bunions, from severe on the left, moderate in the middle, to mild on the right. You can really achieve very powerful corrections with the minimally invasive technique, much more so than you can do with a scarf. Now, I'll admit there are some excellent scarf surgeons out there who will take on significant deformities, but for the average surgeon, they wouldn't. But for the average minimally invasive surgeon, once they've reached competence, they should be able to achieve these sorts of corrections. So you've got a restoration of the intermetatarsal angle, which are these red lines, and a restoration of the hallux valgus angle, the other red lines. If you are an open surgeon, you're much more likely to do a lapidus procedure, which has a completely different recovery, or you might even do a fusion. Again, maybe a faster recovery than a lapidus, but you're going to be sacrificing the joint just because you've got a severe bunion. And that really is not necessary in my hands. Amit touched upon the proximal IMA, or locking the TMTJ out. So if you look where the blue arrow is pointing, there's a gap between the first and second metatarsals. And if you look at the right-hand image, the blue arrow is pointing to a much bigger gap. The green lines have increased in their angle on the second image because I've opened up that unstable first tarsometatarsal joint. I've cranked it out. I've done my shift and correction, then I've locked that in position. You can't do that with a scarf. There is no way you can open up the first TMTJ and lock it with a scarf. The principle of locking the first TMTJ out is extremely important in terms of recurrence. Once you've locked that joint, it's not going to move anywhere. You're not going to get recurrence with this operation. With a scarf, as I said, you don't and can't open up that proximal intermetatarsal angle. So you can't lock that first TMTJ out. Amit was talking about something else. I think he was talking about closing down in the opposite direction to what I'm describing, the first TMTJ. So I'll be interested to hear exactly what he means when he showed that X-ray previously, because it doesn't quite make sense to me. So yes, you do have small incisions, and they do have, and that does have significant advantages. You've got less chance of a wound infection. You've got less wound healing problems. You certainly have less pain and less swelling as well. With a big incision, you've got the opposite. You've got a longer wound, more chance of getting an infection, more chance of a wound healing problem, more pain because you're stripping off all the soft tissues, and because of that, you'll have more swelling. Minimally invasive surgery is extremely precise, much more precise, I believe, than a scarf or open procedure. Because I don't use or need to visualize directly with my eyes, I use x-rays throughout the whole operation. So I can look at every single anatomical landmark, and if I'm not happy with the position I've provisionally placed the bone in, I can tweak it and change it and re-x-ray, and then look at those parameters again to evaluate them to see if they are exactly where I want them to be. So I've got this constant anatomical evaluation radiologically. So in open surgery, most surgeons don't use x-ray. It's just eyeballing and it's imprecise. A minimally invasive approach has the ability to correct in 4 dimensions. So in the coronal plane, you can translate, which you can do with a scarf. You can tilt, which you can do with a scarf. It's got sagittal plane correction, so you can move the bone up and move it down. You can do that with a scarf, but less so. But the one thing that you can't do with a scarf adequately, in my opinion, is the rotational correction. So when you have a twisted hallux and you need to derotate the metatarsal head, the scarf just isn't powerful enough to do that. So this is a good example of one of my patients. If you look at her toenail on the left image, you can see it's just pointing completely the wrong direction. And now after the correction, it's perfect. And that's because I've derotated the metatarsal head. I'm not derotating or cheating doing an Aiken osteotomy, which often the scarf surgeons would do. This is a true rotational correction to give anatomical alignment and better function. So here's an example of a scarf. You can see the toenail on the right-hand side is pointing in incorrect direction, and there's not been adequate rotational correction. So in minimally invasive surgery, I don't violate the joint. So there's less stiffness in the joint and less swelling. If you look at my incision down on the bottom, you saw the video, I don't go into the joint. An open scarf, you flail that whole bone open, you peel off all the soft tissues, you open up the joint, all that's going to lead to is arthrofibrosis and stiffness. I also don't do a medial plication, which you routinely would do in a scarf. So it's one less thing to fail, one less thing to go wrong. So this is typical range of motion after a minimally invasive bunion correction. So if patients ask, can I get into heels again after surgery? Yeah, of course you can. I'm more than happy for patients to get into heels once they've recovered. There's a tendency to undercorrect with a scarf osteotomy. You've got a very powerful means of correction and shift with minimally invasive, but time and time again, I see patients come to see me who have been undercorrected. The soft tissue correction has been relied upon to pull that toe straight, and it's bound to fail over time. And I see patients who require revision surgery, which I do minimally invasively, who've had a previous scarf osteotomy. So I can achieve big shifts. So this is a 100% shift virtually. You can really translate the metatarsal head right across, lock out that first team TJ, and get a really nice correction. You get complete anatomical restoration with new bone. When you do the shift at 6 weeks, you can see some new bone forming where the red arrow is pointing in the middle picture. And over by 6 months, you've got brand new bone that joins the metatarsal to the head. So it's just a delight to see. You don't get that kind of remodeling with a scarf. And once you do have it, you know that patient is going to be happy, good function, and no recurrence. I mean, Amit did mention that, and I do agree with him, that 35 to 40 minutes is perfectly reasonable, even if it's an hour and a half. If a patient wants one operation for the rest of their life that's going to be good to them, I think it doesn't really matter how fast the surgery is. However, As a surgeon, we all like to be efficient. We like to treat lots of patients where we can. So in my hands, I do a Mika in 20, maybe 30 minutes. Yeah, it might be a little bit quicker, but I think you can reduce the risks of having a patient on the operating table, reduce the risk of infection if it's a shorter operation, and so forth. So there are advantages. In general, minimally invasive surgery is very versatile. So while I'm performing a bunion operation, I may need to do other procedures as well. Patient might have a hammer toe, a deviated toe, a second toe, and minimally invasive surgery really lends itself to addressing those other deformities at the same time, very quickly with minimal morbidity. So you can correct hammer toes, mallet toes, do your PI-PGA fusions minimally invasively, correct coronal deformities, perform colectomies for arthritis, and then you can just continue. The list does go on with the versatility of what minimally invasive surgery can do, not just for bunions, but also for many other things. And I think when you're dealing with a patient who's, for example, diabetic or has other comorbidities, then the minimally invasive surgery really lends itself well because you've got minimal soft tissue disruption, you don't have big open wounds, and for patients who are at higher risk of wound infections or wound breakdowns, then MI surgery really comes to the fore over any open surgery. So this is a good example of a forefoot deformity, multiple lesser toe deformities, and if you're going to correct those with the open technique, you'd be making incisions, probably several more than those incisions, on each of the toes. Whereas the MI surgery I can remove all of those long incisions and do very small puncture incisions, which are in between the toes. You don't even see them and they heal brilliantly and achieve a very good result. I've saved this to the end, really. Faster recovery. The jury probably is still out in terms of what truly is faster recovery. You have to really define recovery in order to have this debate, though. But the principles are there. The incisions are smaller, patients have less pain, fixation's stable, it's day case surgery, you're immediately full weight bearing, no crutches, no plaster, and even that by itself, compared to a scarf or perhaps a lapidus, does lend itself or set itself up to a faster recovery. I've had one patient do a half marathon at 6 weeks. Now, that wasn't advised. I didn't tell him to do that. I was a little bit shocked. But patients don't have much pain or if any pain, and they can get going pretty quickly, particularly the younger patients with strong bone. And it is a remarkable difference compared to the scarf osteotomy. Now, not all open procedures are going to be placed in plaster. I get that. Not all open procedures are going to be in a wheelchair or need crutches, but there are plenty of surgeons out there, plenty of operations out there that do require, when performing open surgery for bunions, plaster, crutches, non-weight bearing, overnight stay, more pain, larger incisions. So what are the disadvantages of minimally invasive surgery? Well, it is, as Amit alluded to, a difficult operation. And there is a long learning curve. Surgery is difficult. And when you're coming to this procedure, it does take time to learn. You have to be very careful, very considered, have the appropriate training, do the appropriate courses, and take the appropriate time. So it isn't for everybody. Lots of people start and then give up because they just can't grasp the concepts or it just isn't for them. And I completely understand if you're a good surgeon, does a scarf osteotomy, and you're happy and you're happy patients, then yeah, why would you change? For me, I did change, and I'm happier, as are my patients, for that. So let's look at the literature. Just to wrap up, the literature does support wholeheartedly minimally invasive surgery for bunion corrections. References below, happy to send copies to you. Some of it is my own work with my co-authors. Others are around the world. But in summary, improved patient outcome scores, improved radiological parameters, low recurrence rates, a full range of deformity corrections, and similar complication rates to open surgery. Now, Amit did mention some of the literature. He mentioned a randomized controlled trial in 2018. I think we need to be careful when we look at the literature, because not most of the literature, apart from this one paper, actually compares scarf osteotomy to the current third generation minimally invasive bunion correction technique that I use. And the term third generation just means with screws, and there are a whole different types of third generation operations. So you have to read the papers carefully and compare like with like. But let's look at this one paper. This is by Peter Lamb's group in Sydney, Australia. He looked at 25 PICA, which is a percutaneous chevron Aiken, versus 25 scarf. He published 2017. So 2-year follow-up. Both groups improved in their functional scores. The corrections were similar. PICA was faster to do, and they had less pain. There's been 2 meta-analyses. Again, there's a heterogeneous mix of different types of minimally invasive surgery techniques, but overall good clinical outcomes, low recurrence rates, low morbidity, smaller scars, less pain, short operative time, quicker recovery, but that is with a mixed technique. So I published a couple of years ago with my group 292 cases. These are all the surgeries that I'd done with the MICA or minimally invasive chevron Aiken. So we had 333 feet in total. So over a 4-year period, we had good follow-up, 88% for outcome scores. These are the radiological corrections, so good corrections in the hallux valgus angle going from green to blue, and good corrections of the intermetatarsal angle going from green to blue on the right. And we looked at post-operative outcome scores at 2 years using the MOXFQ score, showing excellent improvements in pain and function at 2 years after minimally invasive bunion surgery. So a few more papers we published since then. So reach out if you need some copies. So I'll just finalize with just a few nice pictures. So I just wonder what Amit would do with this patient. So I did a minimally invasive chevron Aiken, and that was the result. These were her x-rays preoperatively and postoperatively. It'd be interesting to see and hear Amit's views on what he would have done with this case. And a few more. So it really is a very powerful means of correcting a whole range of different deformities. So I believe minimally invasive surgery for bunions is better than open. It's safe, very effective. It's got low morbidity. It's more versatile than scarf. It's got excellent and good outcomes. The recurrence rates are low, and the patients are satisfied. So I rest my case. Thank you.
Thank you so much, David. Some amazing results and definitely some good points to be arguing with. Amit, we have you back, so we're going to get your presentation back open. I think we are just getting to the end of your slide on myth busting. We're just moving on to the next one, but I'll let you get back to it, and then we'll go on to our argument after that, if that's okay.
Thank you very much. Good to be back. Luckily, I live right behind my parents. My internet went down, so I've made a short trip across.
Some cardio for the evening done.
So I think I was at this slide. Is that correct? Apologies to the viewers.
Yeah.
Good. So I think I was busting some myths, and I think we talked about the speed, and I think David agreed that 30 to 45 minutes in itself isn't a long time. Just to address David's point about the first TMT. So I think I gave that one to David, and I did say that, and I was talking about pulling the proximal fragment inwards to lock it out to prevent recurrence. And it's certainly a principle that I hold true. But I will show you some examples of more severe deformities corrected by open scarf in a second. But let's talk about the scar. David showed some very nice pictures of 2 or 3 small scars. What I would say to you is that those 2 or 3 small scars that David showed are often they often look like this. So they're often a little bit stretched. And a single sweep across the foot like this often fades away into nothing. This, in fact, is not even my best example. And most scars look like this at 9 months to 1 year, where you can barely see them. So in my view, the scar really is not a reason to go MIS, and open scars heal well. Recovery, again, going back to David's point about recovery, it's difficult because one has to define, as he says, what is recovery. Is going back to the gym at 6 weeks important? It may be to some people. I think we have to decide, who are we treating? We're treating generally normal people who want to get back into life as soon as they can. But what they want, going back to that point originally, is they want one operation done well. I think most patients are happy to understand it will take 3 months to recover from their surgery. They're happy to stay out of the gym for that period of time, stay out of running, for example. But there are a number of techniques that we use as open surgeons. I certainly do, and that is to preserve the dorsal capsule. By preserving the dorsal capsule, we preserve blood supply. David alluded to flaying the foot open. True, some surgeons do that, but some of us take care. And if one takes care not to flay the metatarsal open to preserve soft tissue, we reduce stiffness. And if we're able to also wash out all the bone debris that we've created with our scarf cuts, in my view, I think that's easier with open surgery, we reduce the risk of creating inflammation. And the more bone debris that's left back, the more inflammation that there is. And it's very difficult to compare, but the patients that I've seen who've had minimally invasive surgery and who've come to see me because they've had a complication or they wanted a second opinion, the recovery, in my view, is very similar in terms of swelling, in terms of stiffness, in terms of endpoint. And again, it's very difficult to compare because ultimately you need a high quality randomized controlled trial. And my patients, they're in a heel weight bearing shoe from 4 weeks. They move into trainers from week 4. All patients have a ankle block. And I would say 90% of patients come to me at week 2 and say, Mr. Amin, I've heard all the horror stories about bunion surgery and how painful I was told how painful it would be, but in fact, I've had almost no pain. And it comes down to modern anesthesia, regional anesthesia, blocking the pain pathways. Patients wake up with no pain. I do the surgery awake as well. And if we block the pain pathways, control pain at the beginning, most patients don't actually have any pain. This is an example of a patient I operated on sequentially. She came back to me after 3 months and I said to her, how's it going? She said, everything's brilliant. I've been running. Now, again, not a goal. I don't tell patients to run at 3 months. Some do get back to it. I think it takes longer. But recovery can be quick in some patients. Now, what about extreme deformity? Now, David, I think, suggested he was going to ask me what I would do with his patient who had a fairly similar deformity to this. And my answer would be an open scarf. Presuming the patient was a good specimen who had good blood supply, didn't have comorbidities. Now, again, I would give this one to David. The patient was high risk with peripheral vascular disease and diabetes and had this presenting X-ray. I'll be getting on the phone to David and referring the patient on. But the majority of patients will present to you with reasonable skin, with good blood supply, with minimal comorbidities. And in this situation, you see here, I performed an open scarf. I've been able to derotate the toe by dealing with the soft tissues, by pushing and rotating the metatarsal head into position, and then by rebalancing the toe, that ultimately rebalances the actual toe itself in terms of its pronation. And I may have cheated a little bit through here with my aching osteotomy, but only a little. And this is the 6-week X-ray, and this is the 3-month X-ray. You can see a very nice correction. Just to prove that it wasn't a one-off, this was a patient I operated on recently. Again, severe deformity, often thinking about doing a lapidus procedure, which I'm doing less and less of, because we're able to really push the scarf in now and rotate it. And if you're able to push it in and rotate it, you can get a pretty good result. I know time is short. I'm going to get to the end of my talk very soon, but I just wanted to talk very briefly about complications. Look, as a surgeon, all of us will have complications. These are the complications of minimally invasive and open surgery. But what I would say, just as a point in note, non-union and delayed union are very rarely, if ever, seen with an open scarf osteotomy, but reasonably commonly seen with a minimally invasive approach, because it's ultimately the bone is burnt despite meticulous technique, and sometimes that can delay the healing potential. And avascular necrosis of the metatarsal head, again, comes with stripping of the metatarsal head, but I have seen it more commonly in patients who've had a poorly performed minimally invasive technique. So just to sort of finish here really on one of David's papers, this is one of David's studies on 106 patients. This was a high quality study, excellent clinical patient-reported outcome measures, 2 years following surgery. Results were good, but I'll just draw you to the complication rate. Now, of course, complications can come small and big, but there was a 1 in 5 complication rate, and 1 in 20 patients had to have screw removal, which is almost unheard of with open surgery. So just a point to note that we can't get away from complications. They exist, and they exist in 1 in 5 patients with a minimally invasive approach. So just in conclusion, I think it's quite clear that open surgery is the gold standard approach to bunion surgery in the UK. No high-level study has shown MIS to be superior to open surgery, only equivalent. Scars fade away. I think we can move away from that one pretty quickly. Recovery takes time, in my view, whichever the approach. And I've shown that large deformities can be corrected with an open scarf. I think the real points here really are, the real pertinent points are that training in MIS is very rarely accessed through traditional NHS registrar training, and it requires therefore a significant on-the-job learning curve in the early years of a consultant life, and unfortunately that does result in a significant number of poor results. And as David has shown, there are some situations where there are significant deformities in patients with multiple deformities, perhaps, or with comorbidities, poor skin, peripheral vascular disease. So minimally invasive surgery is certainly the approach in that particular group of patients. And I believe that minimally invasive surgery is here to stay, but I suspect it's going to be coexisting alongside the gold standard, which will be open surgery. Thank you.
Thank you so much, Amit, and thank you for definitely doing your quick journey over to get your internet sorted. It was definitely appreciated. So we are tight in time, but we kind of knew this was going to happen. As I said, this is a huge topic. We could spend hours, if not days, talking about it. So let's get over to the debate then. So like I said at the beginning, I'm going to give Zoe the first go, and then we'll move over to Liam. So tonight, Zoe, you have a big challenge. It's only going to be 3 minutes. If you're happy to, I'm going to start the time whenever you say that you're ready to go.
Okay, I'm ready to go. Thank you very much, first of all, to David and Amit for a fascinating overview of both minimally invasive surgery and open surgery. So my battle is with open surgery, and I don't think it's a big battle with it being the gold standard. And as Amit has alluded to, we all have there's complications with any type of surgery performed. But what we can see from some of the literature, that there is some complication rates with regards to certain techniques of minimally invasive surgery. Now, we know with open surgery, we can address all different types of deformity, that being mild, moderate, or severe, and those being distal, diaphyseal, or proximal. So not only can bunions be addressed in the mild deformity, but also in the severe deformity. We also discuss quite a lot about training competency. The minimum requirement is cadaveric training, which is mandatory when learning minimally invasive surgery. But as we've alluded to, if I was having bunion surgery, I would surely want a surgeon who is competent in that procedure. And how many procedures is that, and what does that look like? It's a steep learning curve. And as we've alluded to as well, open surgery is already a complex procedure with regards to hallux valgus surgery, as much as hallux valgus is a complex pathology as well. So it's a steep learning curve, and it's even steeper when we start to make 4 different percutaneous entry points and then try and direct screw compression and fixation through those various sites. So minimally invasive surgery, what does it actually mean? And what are the myths that we kind of come across in terms of surgery? And that is that the recovery time is reduced. And I would certainly say that we're still making bone cuts. You know, we're still seeing patients who are having to recover from essentially fracture of that bone. The other thing that I came across was that patients are exposed to fluoroscopy intraoperatively. So there's a lot of radiological involvement there intraoperatively. But I do agree, certainly in terms of precision, that's a huge advantage. So essentially, how long have I got left?
Sorry. 36 seconds.
All right. You don't know what you can't see. And if it ain't broke, don't fix it. My opinion is that visualization of the structures involved in open surgery far surpass those of minimally invasive surgery. I think it's a very exciting time for bunion surgery and the advances of modern techniques, and those I do not deny. But I ask you, who is the true winner of hallux valgus surgery here?
Amazing work. You did it right on time. Okay, so let's move over to Liam for you to give your argument. Just tell me when, and I'll start your time as well.
Yeah, thank you, Nancy.
That's us going.
Perfect, guys. So, David, thank you very much for that very in-depth presentation. You covered all my points, far beyond any points I could bring into this debate. So thank you very much. And thank you very much for stealing a lot of my points as well that I was going to bring in today. The argument has been extensively put forward by David. And I've heard this twice now, one off Zoe and one off Amit. If it ain't broken, don't fix it. And I just want to think about that for a moment, because before, 1980, to 1960, ACL surgeries were all open. And then following kind of 1980s onwards, ACL surgeries were then arthroscopic. So is this, if it ain't broke, don't fix it? Is it coming from a sense of, do you feel comfortable with MIS surgery? Is there a place for MIS surgery? And actually, did we, we really could have brought that, I suppose, medical psychology and terminology really from 1960, 1980, and now is the gold standard to have an arthroscopic procedure of your knee with ACLs. So is it going to be an approach really for pod surgeons, orthopedic foot and ankle surgeons in the future, or not? And really, it's just a thought-provoking debate. I'm not going to argue the fact that it's a shorter recovery time, it's minimal scarring, there's less trauma, there's reduced stiffness around the big toe joint. I'm not going to argue that because David's put that forward. But what I am going to argue is this an old hat? Do we need to move on? Do we need to get comfortable with MIS? And can we then potentially look at identifying the specific cohort of patients that would benefit more from MIS than traditional surgery? And that's me done. Thank you.
Amazing. Done even earlier. Oh, you had a whole minute to go.
I did.
We got marks on that. But anyhow, we'll leave that to our audience to decide. Thank you very much, everyone, for giving your input. What we'll do now is we'll move over to our discussion and our questions. We've had a few questions come in. I've got plenty myself, so I'm sure we've got way more time to kill, but we'll try and go through them nice and quick. So firstly, we have a question from Ian Riley, and that was specifically going to David. So David, Ian was asking, how about 50 minimally invasive surgery bunions versus 50 open as a prospective study? And I'm assuming when he put those brackets in, he's thinking ortho versus pod surgeons. What do you think of that?
Hi, Ian. Thank you very much for the question. Good to hear you or hear your typed question. I think that we probably all can agree that one randomized controlled study by Peter Lamb in 2017, SCARF versus PICA, 25 patients each, may not be enough numbers. And I think we could continue having this debate for many years to come unless there is a well-powered randomized control study. So I don't know whether you'd have to have or could have two different types of surgeons who had different sorts of training do one then the other, because then that's going to be open to bias, saying, oh, well, so I think you'd have to have probably a single surgeon who's competent in both, randomized, good numbers. And I think 50, maybe even more, would be a good number to pick up all those smaller, lower risk complications. But yeah, that's ultimately what we should do. But as you know, setting up studies like that, gaining funding, it's a huge amount of work. And there are emerging similar studies in Lapidus, actually. So watch this space, not my space, but Over the Water in America, where they do a lot of Lapidus, comparing MI Lapidus with open Lapidus. So yeah, I think it's a great idea. For me personally, I'd love to do that, but I'm just embarking on following up the 2-year results that I published and looking at those same cohort at 5 years. And it's going to be really interesting to see when we look back at a whole range of different radiological parameters, many more than I did initially, to see whether there are distinct additional advantages in deformity correction radiologically with the minimally invasive technique. But yeah, I hear your point.
Thank you so much, Ian, and thanks, David, for that answer. Now we've got a question from Louise Reaney, and this is a question I'm going to post to both of you guys, David and Amit. Are there any differences in post-op pain associated with these procedures? Amit, if you'd like to go first and give David a wee break.
Sure. Yeah. So yeah, I alluded to it a little bit in my talk. A lot of patients, first thing a patient says to you when they come to see you with a bunion is, I've heard horror stories about how painful this procedure is. And it's very interesting how common that comment is. And part of my counseling is to reassure them that 9 out of 10 patients will come to me at 2 weeks and tell me that they had almost no pain whatsoever. And it comes down to a number of factors. Firstly, the inherent stability of the scarf osteotomy. We talked about how we cut the bone in a Z fashion, how that's very stable. We fix it with screws. So we've inherently fixed the controlled fracture that we've created. And again, meticulous technique, washing out the wound, being very careful with the soft tissues, not stripping the metatarsal head. And then regional blocks. So again, I will happily talk to a patient. I've had many patients sit up and watch me do a bunion operation. Yeah, the brave one, certainly. The block makes a huge difference to the recovery. So if we have a successful block, a patient wakes up all happy and dandy, no pain. Cover that little period when the block wears off with some basic painkillers. Most patients don't have any pain.
Amazing. David, do you want to come in on that as well and give a wee response?
Yeah, I think I'm certainly in agreement with Amit. We probably have a very similar cohort of patients who come and see us regardless of what technique we decide to use. And it is a very, very common concern for patients that it's going to be a very painful operation, because it used to be. And it used to be because, I think, primarily because of regional anesthesia and the advances that now exist. And so I have a very similar experience to Amit in terms of very, very low levels of post-operative pain, if any, after surgery. The literature, however, looking at that randomized controlled trial and a few others, have shown that MI surgery versus open surgery, those patients had lower narcotic use and higher pain scores after surgery. The devil may well be in the detail about how they were anesthetized, what blocks and what regional anesthesia was used. So there's the literature is telling us that MI patients have less pain. But obviously, anecdotally, we are probably in agreement in terms of regional anaesthesia is really the key, and we have our anaesthetists to thank for that. But it may be the lack of soft tissue stripping and the smaller wound that also lends itself to less pain as well.
Absolutely. For once, we have two people agreeing on this show. It's nice to hear it. I'm going to pass it over to Liam now quickly before we go over some more questions from our audience. I know Liam has a burning question to ask you both.
I do. So Amit alluded to this about the reproducibility, really, of a scarf and aching. And it's a comfortable open procedure, isn't it, for a hallux valgus? But the question is really for David, is that, you mentioned first generation, second generation, then third generation kind of chevrons as you go, I believe, further distally down the first metatarsal. How far off are we on reaching kind of the perfect generation of MIS surgery, if that makes sense?
Thanks, Liam. So it's not quite accurate to describe how you did. I'll explain what the generations actually mean. So the first generation is any cut in the bone to resolve the bunion, but no fixation. Second generation, any cut in the bone, but with a wire, a big, strong 2 mm K-wire down the intramedullary canal to hold the head in place. Third generation, again, any cut, normally it's a distal cut with screw fixation. However, there's generation 3.1, 3.2, 3.3, because as the third generation has evolved, the way we put those screws in has differed. Some using 1 screw, others 2 screws, sometimes purchasing the lateral cortex, sometimes not. So we're really moving into fourth generation now to define screw fixation, purchasing the lateral cortex, which is important for rigidity, either as a flat cut or a chevron, but basically rigid internal fixation with that screw configuration. And we've recently published, Robbie Ray was the senior author on that paper. He presented his year outcomes, 1 year outcomes. I'm co-author on that, describing what fourth generation is. That's probably a term that you'll now see. And all it does is describe a 3.5 version that we've already been doing, but just wraps it up into a more meaningful and recognizable generation. Because, Amit mentioned some papers, and yes, some of them are third generation, but I could list you 5 different third generation papers. The techniques are all different, so you have to be careful. So are we reaching a holy grail? Well, look, we're in medicine. This is science. We don't stand still. And that's part of the reason why I progressed from the scarf to minimally invasive, because you're always trying to strive and achieve the better. So we will never get there because that's just human nature. So we have to keep on trying, do the best for our patients. So this is just we stand on the shoulders of giants, and others will stand on our shoulders. So we just keep going.
Thank you, David. So I'm going to jump to Zoe, who also has a question just now, and then we'll take another question from our audience.
Thank you very much. What I wanted to ask, this is something that has been going through my mind for quite some time, because obviously when you've got this steep learning curve and you're learning these techniques and you're teaching these techniques, I don't know, David, whether you teach other surgeons this technique as well, but what do you find happens if, with these higher rates of non-union that can be seen due to compression of the screw or various complications in positioning of the screw, how do you address a non-union? And do you ever have to revise these procedures via open surgery? Is that how you would reposition and revise?
So thanks, Zoe. So absolutely, there are risks with all surgery, and I agree with Amit that there's an increased risk of delayed union or non-union with the minimally invasive approach. I'd just like to pause there and Amit very kindly referenced myself in the 106 severe patients that I published and talked about the 18% complication rate. I just want to validate that, because I document everything. I'm quite anal like that, and I'm happy to volunteer. I think it's important learning for everybody. So every single complication I had was documented prospectively, and that's what we published upon. Down to some numbness on the top of the toe. that's a complication in my book. Is that a significant patient impact complication? Not really, it's just a bit of numbness. So it's just important to take into context what that 8% complication rate really means. You've actually got to read the paper and see line by line what they are. And the screw removal rate is part of the learning curve. So my screw removal rate is about 1% now, whereas 5% in that paper. So moving on from there. So non-unions and delayed unions, they do happen. So I use bone stimulators, an next-gen device. It's a pain-free stimulator, sometimes a period of immobilization in a boot, but for weight bearing. And in terms of revisions, so I follow up all my patients very carefully. So I generally know what happens to most of them. If they don't get back to me, my good colleagues tell me because I'd like to know. So in my personal experience, I've revised 4 out of close to 1,000 for non-union. And I know of, I think, 2 others who have been revised by other surgeons. There probably will be more, but the numbers are small. When you do a lot of something, there's benefits and there's also issues, because if things happen, they happen more frequently because you're doing more, but percentage terms, they are the same. But it also means you can react quickly when you're a high volume surgeon doing a lot. You can identify issues and change practice. And I've certainly changed practice, and I still do evolve the techniques. The video you saw, which was filmed about 18 months ago, I do it differently now, slightly, very small step changes. But when it comes to revising, I try and do that when I can minimally invasively. I can slide a plate percutaneously to stabilize an unstable. But if it needs bone grafting, again, I'll try and do that percutaneously. Sometimes you need to open it. It depends. If you're putting bone graft in and you need a block, then clearly you need to open it. But I've only had to do that once. So yeah, I try and do things where I can minimally invasively, and of course complications happen. But I think it's important to consent patients honestly and accurately. And I use my data that I published in order to do that. So I'm very transparent.
Thank you very much. Thank you.
Amit, do you want to jump on to any of those points that David's made, or are you in agreement?
Yeah, I'm in agreement. David's you've clearly done a huge number of these cases. I think just a question for David, perhaps, if I could. It seems somewhat of a shame that you're not able to pass on your skills to the next generation, apart from, of course, teaching in cadaveric studies and teaching on cadavers, which, as we know, is a good starting point, but it's not the real thing. And the complication rate that I put up there, I'm sorry about that, but I think we've qualified it. Look, that's in your hands, and a surgeon in their early learning curve, the complication rate is going to be higher, screw removal rate is going to be higher. What's your views on training in MIS? And it's easy because you're a high volume surgeon, you're doing lots of cases and you get good results, but how can this be generalized to the surgical community?
So I absolutely agree with you, Amit. And like you, we both left the NHS at a similar time, about 7 years ago. So I don't have registrars. I don't train registrars. I am involved in teaching and training, but it's not quite the same as having a fellow who's with you for 6 months and you really get to teach them all the nitty gritty about the surgery rather than spending a couple of hours with them over maybe a day or so. I think for me, it's just about time management in life. And when you're in a busy practice, it's useful, and I really enjoy teaching. So it would be great to have a fellow, and I have tried in the past. And then you have this issue of funding. Who's going to pay the salary of the fellow? Are the companies engaged and involved and want to? And previously, I found that that's not been the case. So yeah, I'd love to set up a fellowship program, and I do have plans to do that in the near future. But I think unless you have a huge range, a great number of surgeons in the NHS training registrars, me alone, I could train 2 people a year competently, I would have thought, if they come to see me for 6 months. So, when I retire, it's not that many surgeons, but obviously they can disseminate. But I think it's difficult. And I think unless people surgeons want to take that leap of faith, learn the procedure, take the bumps that go along with it, and then train others. It will take a long time, and I don't really have an answer for that apart from getting more consultant level surgeons learning technique and then training their registrars. Well, I'll tell you what we should do, and we should have a one fellow that basically trains with both of us. We can have a shared fellow, and then see where they end up, MI or open.
Let's do it.
That sounds like a brilliant plan to sort all of this out. Liam and Zoe, do you have any more questions that you want to go to, or will I move over to some more audience input?
Just on that one, actually, a question for Amit, if that's okay. But for our kind of budding podiatrists that want to train to be podiatric surgeons as well, just can you give us a guide as to, we talk about competence of doing MIS, for example. What about the competence of doing kind of open surgery? So how many surgeries do you think it will take for any trainee surgeon to actually feel comfortable and competent?
Yeah, very good question. As I said, I'm 12 years into practice, and I've probably just come to the end point of seeing all the potential complications that can occur with bunion surgery. It's part of orthopedic higher surgical training. You have to do a certain number of bunion surgeries to get signed off at the end of your training. I think that number isn't actually that significant, and it's diluted amongst chilectomy and various other first-rate procedures. Things may have changed. I haven't been in the NHS for a while. But as a consultant, in my view, I personally do about 50 to 60. I don't do huge numbers. I do about 50 to 60 bunions per year. That's not a lot, but over a period of time, that equates to a large number. Technically, it's a very challenging procedure, and it's one that, unless you've had good instruction from someone who's done a lot of these surgeries, who's you've been trained within the NHS, you worked with a good foot and ankle surgeon, maybe done a fellowship. Typically these days, when you do a fellowship, you go abroad, and quite often, bunion surgery isn't the thing that the surgeon really wants to do. In Canada or America, they want to do ankle replacements and things. And so the exact number is difficult to put a finger on, but it's, in my view, a good 100 cases. Once you've got to about 100 cases, I think you've started to experience what can go wrong. And I think it's about what can go wrong.
Yeah, thank you. That's a lot, isn't it?
Absolutely a daunting task to look to, but we definitely have a lot of people in our community in podiatry anyway that would be definitely keen to look at your joint fellowship option. If that is ever on the cards for any of us, we'll definitely be lucky to have that on our screen. So I'm going to move over just to a question or two. It depends on how you guys are feeling. I know we're kind of going over on time, and I hope our audience are still with us. But I do have a question from Noreen, and I think this was after David's presentation. It was, she asked whether it's recommended to be full weight bearing after minimally invasive surgery for a bunion, and also what does happen with bone debris within minimally invasive surgery, as Amit has kind of alluded to.
So I would say, I don't have the exact numbers, but maybe 90% of all my patients will be full weight bearing in a flat sandal after surgery, no crutches, unless they're bilateral simultaneous, in which case I have crutches for 24 hours because they've got numb feet and it's a bit awkward to walk on. There are a few selected cases where patients with osteoporosis, weak screw fixation or weak fixation, I'm a bit more cautious, and I might use crutches, 50% weight bearing, for 2 to 4 weeks until you've got some consolidation, some healing, and then allow them to full weight bear. So it's based on patient selection and the history, and also the x-rays, the radiographs. You can see the quality of the bone, and then you're feeling how firm that screw is when you're performing the fixation. In terms of the bone debris, well, what happens is the burr spins and it's under irrigation. So there's a jet of fluid being squirted into the wound that reduces the heat damage to the skin. but also you get a little bit of fluid into the wound. So when it's kind of whizzing around the burr, it actually forms a paste. So it's a bit like toothpaste. So the hard bone gets ground up, and initially you just squeeze it out. And then at the end of the operation, which you didn't see on the video, I spend about 2 minutes just irrigating, wash, I'm just washing all the time until everything's clear. Mm-hmm. So there tends to be no debris left. I've had probably one patient in, as I say, near 1,000, where they've grown a little spike of bone because they didn't wash out enough in the early stages. Maybe more than one, but literally a handful. So that is a risk, but that's why I just meticulously wash out the bone. But bone, as we know, is living cells, and if you leave them in and they've got a blood supply, they can grow. So it tends not to be a problem.
Amazing, thank you, David. And before we finish, I'll just summarize a wee bit with Angie. So Angie in our comment section has said, surely improvements to techniques should always be considered. Surgery is moving at a rapid pace, and to leave it as it is, as in if it ain't broke, will stop any advancements. So yeah, that's kind of what we were all going through with Zoe and Amit stating that. And I know Liam then came back with a good thought on that and a good reflection that we had for there. And then finally, Angie asked, do you discuss with the patients the different procedures, and will you accept their decisions, or will you try to sway them to your preferred procedure? David, I know that you did tell us you use your literature and you also use your evidence from your previous practices. But Amit, could you come to an answer for this for Angie?
So the majority of patients who come to David have usually looked him up, or that someone's been recommended. So they've come in to David to have minimally invasive surgery. So there's probably no discussion. When patients come to see me, I would say that 9 out of 10 patients do not even raise the question about minimally invasive surgery. I will tell the patient there are 2 ways to do it, but I do it through an open approach. And again, because lots of patients come to see me through recommendations or have been sent, that they're happy to go with my advice. And the patients who do want to choose an MIS approach, the 1 out of 50 probably, I'll send to David. But generally patients have done their research. They've understood that there are different approaches, and I essentially give them my experience. And if they want to go down the minimally invasive route, then I refer them on. So there's no issues with that at all.
Perfect. Thank you so much, Amit. So we'll first give our final result from our poll, and then we'll do our sum up. So from our poll, the results are in. Minimally invasive surgery, 33% of our audience voted for minimally invasive surgery, and traditional with a whopping 67%. So congratulations to Zoe and Amit. Well deserved. Thank you so much to all of our speakers as well tonight for giving such great points. And thank you as well for staying on late. I actually knew it was going to go on until 9:30. So in fairness, I think we're all happy enough to be here. So I'll pass it over to Zoe to do your quick sum up, Liam sum up, and then we'll all say goodbye.
Sorry, I didn't realise I was doing a sum up. Thank you so much to Amit and David for your fascinating insights into both approaches of hallux valgus surgery. I truly agree that there's some really exciting things coming in foot and ankle surgery, and minimally invasive surgery is one of those. It's lovely to see with the 3rd and as the 4th generation you've discussed, David, that the outcomes are suitably matched to open surgery. I think that's really exciting. So thank you so much, and thank you to Nancy and to Liam and to Michael for your work on this episode. It's been fantastic.
Just want to echo that, guys. Thank you very much, Nancy, Michael, Zoe, everybody, and obviously our 2 experts here. Thank you very much, guys. And yeah, it's gone on a little bit longer, but I think it was really interesting that we had that discussion at the end. Thank you very much for staying half an hour over, and let's close so that you can you get some good night's sleep so you can do some surgeries tomorrow.
Thank you very much, guys. I had a big outro to do, but I'm just going to leave it at that. I think we've said all we need to say, and thank you so much again. And hopefully we'll see you all again at our next session. Good night.
Thank you very much.
Thanks very much.
Yeah, enjoyed it.
Take care.